Good morning, one and all. I'm Dr. Sowmya Vegesna, Cornea Fellow from Vision TI Hospital, Vishakhapatnam. Today, I would like to speak about a case of corneal graft rejection and reversal just in time. Scope of my presentation includes introduction, case report, discussion, management, and conclusion. Introduction: cornea's relative immune privilege as a transplanted tissue. Allogenic rejection is the most frequent reason for corneal graft failure. It should be appropriately identified and differentiated from other causes of graft failure that are not immune mediated, like the primary donor failure. So the diagnosis of a graft rejection, mainly it is based on the grafts that have remained clear for at least 2 weeks following transplantation. The survival percentage for low-risk PKP, primary grafts with immunosuppression, has been reported to be as high as 95% at 5 years. In contrast, failure rates for high-risk recipients, such as those who have corneal vascularization, can easily reach 35% at 3 years. So coming to the case report, a 64-year-old male who had undergone penetrating keratoplasty for adherent leucoma left eye, and for 2 years the corneal graft was clear with best corrected visual acuity of 6/36. He suddenly presented to us with pain associated with decreased vision, and his best corrected visual acuity dropped to CF 1 meter. On slit lamp examination, there were DM folds and stromal edema, and the graft was relatively hazy. Management: we admitted the patient and administered oral steroids along with intensive topical steroids. The patient showed dramatic improvement in vision to 6/60 with decreased corneal edema and DM folds over the next 48 hours. Discussion: cornea being an immune privileged organ, the success rate is higher in keratoplasty compared to other transplantations. The other factors playing a vital role in this success are avascularity and lack of lymphatics. Risk factors that raise the possibility of rejection during corneal transplant surgery, such as preoperative inflammation, corneal neovascularization more than 2 quadrants, young recipient age, iris synechiae to the graft margin, large grafts, loose sutures, and prior graft rejection. So immune reaction can involve different layers of transplant like epithelial, subepithelial, endothelial, and mixed. Endothelial rejection, there is a white line on the corneal endothelium, which is called as a Caudados line, and also keratic precipitates may be seen. It is always advisable to reduce the active inflammation in the recipient's eye prior to transplantation, and topical steroids are the primary mode of treatment. Epithelial and subepithelial rejection, topical corticosteroids can be used 2 hourly with a tapered dosing over 6 to 8 weeks. And severe endothelial rejection, topical corticosteroids prescribed hourly, that is prednisolone acetate or difluprednate, along with systemic therapy can be used. Calcineurin inhibitors like cyclosporin and tacrolimus are viable options in patients in whom corticosteroids are contraindicated. So conclusion: patient education regarding the early symptoms of graft rejection followed by early detection and timely intervention can have favorable outcomes in cases of corneal graft rejection. Diagnosis of graft rejection should be made as early as possible by an ophthalmist, and this plays a vital role in the management of corneal graft rejection. These are my references. Thank you.